opportunity. I thought glaucoma is hot, but it will be so hot I never realized. So we'll talk in short about the interpretation of visual fields. So this is what a single field analysis looks like, and we divide this for the sake of analysis into various parts. The first part is the procedure information and the patient data. The second part is the reliability analysis. Then we have the raw numeric data and the grayscale. Then we have the total deviation, the numeric and the probability plot, the pattern deviation, numeric and the probability plot. We have these GHT and the visual field indices, including the VFI, and then we have the gaze trigger. So first we'll talk about the Humphrey, and then we'll talk in short about the Octopus. So what this gives us is the name of the patient, because there could be various patients. The ID of the patient, there could be, sometimes two patients with the same name in your OPD. The eye to be examined, the left or the right eye, the date of birth, because the data is compared to the age matched normals. The date of the exam, because the patient can have various visual fields. The visual acuity and refractive error to be properly placed, the pupil diameter, the test strategy, because we can compare standard with standard better, the stimulus size, the type of program. This all is given in the upper part of the visual field printout. Then we talk about the various strategies. We have got 34-2, 24-2, 10-2, and then we have got 30-2C these days. Then we have the standard, fast, and the faster. As we move forward, we have lesser time consuming. So you have to compare the same type of strategy with the previous same type of visual fields. The fixation pointer is usually the blind spot, and it is mapped early. What perimeter does it gives another stimulus at the blind spot. If the patient says that it is seen, then it is marked as a fixation loss. Fixation target is typically a central light. Up to 20% of fixation losses are acceptable. Then we move on to the false positive. The upper limit of acceptable false positive is 15%. So what happens here is the patient does not see the stimulus but press the button. So what it gives you a very high threshold value, abnormally high sensitivity as compared to the normals. The patient is seeing very faint stimulus which is not seen by a normal person. So there is a lengthy testing. GST will show abnormally high sensitivity, and there will be larger defects in the pattern plot as compared to total deviation plot. Then we move on to the false negatives. What the patient does here is he sees the patient and doesn't respond. It could be because of the fatigue or incapability. The mean deviation will show a negative high value. Also, the pattern standard deviation would be pretty high. The foveal threshold, if there is a good visual acuity, poor foveal threshold, it shows early involvement of fovea. If there is a poor visual acuity, good threshold, it points towards a refractive error. Now, this is the second part, which is the raw data and the grayscale. We have to be very careful, because the two adjacent points can't be judged on the grayscale. It can cause depression with the cataract and age, and it is not so very important from the glaucoma point of view, but it can highlight some common artifacts and make the patient realize what he's losing. Then we move on to the total deviation plot. It compares the age-matched normals with the patient. Any deviation by 5 decibels is taken as abnormal. The positive numbers indicate more, and the negative numbers indicate less sensitive spots as compared to normals. And this is again a center weighted, that is, center points are given more weight as compared to the peripheral ones. It is good for the overall, visual assessment, overall health of the vision, rather than the pattern of the vision loss. Then we move on to the pattern deviation. What visual field does is it corrects all the kind of points from the 7th most sensitive non-edge point, and it identifies the glaucomatous defects, that is the defects within the defects, as localized defects. So it removes the generalized depression because of cataract and age and brings out the glaucomatous visual field defects. So in early stages, there will be subtle defects which can be easily picked up, but in the advanced cases, it may be misleading. So in the end stage glaucoma, it can even be reversed. So all the plots, all the symbols which are present in the pattern deviation but absent in the total deviation plot are usually false positives. Then we have the GHT, so it compares the upper half of the visual field from the lower half in the various zones. If the difference between the two zones is statistically significant, it flags it as outside the normal limit. If it is borderline, because the difference is not significant enough statistically. Generalized reduction when all the points are low as compared to normals, abnormally high sensitivity, as I've already talked about, and then within normal limits has to be normal. Then we move on to the global indices. So all the global indices are center weighted, that is, all the points in the center area are given more weightage as compared to the peripheral points. The mean deviation, if there is a deviation which is above 2 decibels, should arouse a suspicion of glaucomatous visual field defects. It is good to analyze, it helps us analyze the overall visual field performance rather than the generalized defects. Pattern gives you a small area which is more within the hill of the vision, which is more depressed within the hill of the vision, like a nasal step or a scotoma which is there because of the glaucoma. Now, VFI is a single numeric metric which represents the whole visual field into a single number. A full visual field will give you 100, and a perimetrically blind patient will give you a VFI of 0. So we all know that the rate of progression could be event-based or a rate-based. So VFI is a combination of both, even in the rate-based analysis. It usually takes into account the pattern deviation plot, but if the pattern deviation is not so good, it can take the total deviation plot also into the account. So it also gives a small value which generates a p-value for it, and p-value signifies how fast or how significant the drop is. And the correlation between the VFI and GPA in almost all kinds of glaucoma has shown to be very good. Now, there are certain points we have to understand about the global indices. The cataract, high refractive error, media opacity will show as high mean deviation as compared to normal pattern standard deviation. Early glaucoma will show a low mean deviation but a high pattern standard deviation because of the focal defects. And they would be similar in both MD and the PSD plots. In cataract and glaucoma or in advanced glaucoma, the PSD would be abnormally low with abnormally low p-value. In advanced glaucomas, the PSD will improve because the hill of the vision will become very flat and all the points will go down. Now, this is the gaze tracker where the patient's movements, cornea movements is recorded. So whenever the patient moves the eye, the upward line is made, and when the patient movements are unrecordable, the downward line is made. So this is how the gaze tracker works. Now we move on to the, in short, about the Octopus. The Octopus also has similar kind of presentation, but in different pattern. This is the 7-in-1 printout of Octopus, which looks like Humphrey's. So this is the procedure information and patient data. Then you have the catch trials, which are similar to the reliability indices. Then we have this raw numeric data in the grayscale, which is colored here. Then you have got comparisons in places of total deviation, corrected comparisons in places of pattern deviation. Then you have got Baby's curve and the global indices. So we talk about them in brief. So this is how the upper and the lower part of the procedure information. So we have the name of the patient, the ID of the patient, the eye examined, the date of birth, the date and time of the exam, the visual acuity, the refractive error, the pupil diameter, the test strategy, the stimulus size, and the type of the program. So almost everything is here which is similar to the Humphrey's. Now, sorry. Just to skip. So this is the gross difference between the Humphrey's and the Octopus. So we have standard, Sita, and Sita fast. We have here normal, dynamic, and top. So we have mean deviation, which is similar to mean deviation of Octopus. The pattern standard deviation is called as square root of loss variance. The mean deviation is called as comparisons. The pattern standard deviation is called as corrected comparisons. And GST is called as cluster analysis. So it gives you almost all the things what we have discussed in the past. So these are the strategies, like we have full threshold, dynamic, and top. So we can clearly see in the area here, the catch trials or the repetition questions and repetitions are much more in the dynamic as compared to the top area, because the dynamic is like a full threshold or a Sita standard, while this could be like a Sita fast. The reliability factor is one more point which is there in the Octopus. The reliability factor has to be more than 15 to be reliable. Then catch trials are similar to the global reliability indices. Then we have another metric here as mean sensitivity, which is inverse of mean deviation. So the mean sensitivity higher means the patient's fields are good, and the mean deviation